Perfect. Well, thank you so much, everyone, for joining. This is the COVID Force Collaborative Seminar Series, and we have two really fantastic speakers lined up. At first, I'd like to introduce Dr. Mehgan Teherani, who is a third-year fellow in pediatric infectious disease. She received her Master's of Science degree in Global Medicine from the Keck School of Medicine at the University of Southern California, followed by her MD at Texas A&M Health Science Center and her residency training in pediatrics at Phoenix Children's Hospital in Phoenix, Arizona. After she finished her residency, she completed a year as a pediatric hospitalist for the oncology division at Texas Children's Hospital before starting her pediatric infectious disease fellowship here with us at Emory. Now, she's actively contributed to the Emory and Children's response to the SARS-CoV-2 pandemic and was the first author on a recent publication entitled The Burden of Illness in Households with SARS-CoV-2 Infected Children that was published in the Journal of Pediatric Infectious Disease Society. She's got a fantastic mentorship team with her primary mentor being Preeti Jaggi, who's associate professor in the Pediatric Infectious Disease Division, and her co-mentors include Andy Shane and Andres Camacho Gonzalez. Her title of the talk is very timely and is Transmission Dynamics of COVID in Pediatric Households. Thank you, Mehgan. Take it away.
All right, thank you. And thank you for allowing me to present today at the COVID Force Seminar Series. So I will be presenting our research on illness burden in households with SARS-CoV-2 infected children. None of the authors have any disclosures to report. So symptoms of acute COVID-19 differ in children versus adults, with children often reporting fewer symptoms and are more likely to be found to be asymptomatic than their adult counterparts. Household settings of index cases appear to pose the highest risk for transmission, as seen in the first bar of each cluster in this paper, with transmission reported early on as between 10 to 17% among households, and is higher compared to other close contact settings, such as public transportation, healthcare settings, or workplaces. Very early studies looking at household transmission from Wuhan, China, also showed that children may be less likely to be affected by COVID-19 than adults. For example, in this study by Wang et al., they report an infection rate of 7% in children compared to 45 and 48% of male and female adults. However, as SARS-CoV-2 has spread throughout the world, we've kind of seen a significant change in this data. So although studies initially showed that children were less likely to be infected, studies quickly evolved. So for example, this study in B et al. Published in The Lancet showed that children in fact had equal attack rates compared to adults, although were less likely to have severe symptoms. And these studies did not address children's ability to transmit the virus and mainly evaluated adult to child transmission cases. So early in the pandemic within the US, there was a delay in reporting of cases in children. Our first case in a child occurred in the first week of March and really did not significantly increase until a few weeks after school shutdowns. So specifically in Georgia, our school shutdowns occurred between this March 13th through 16th week. And as you can see, children were likely transmitting infection to each other beginning around this time, as approximately 2 weeks later, there was a significant increase in acute cases despite these school shutdowns. In addition, this was likely an underrepresentation of true disease burden, as testing capabilities during this time was limited and only used for symptomatic ill-appearing patients. In addition, prior to our study, there was really a paucity of information about child to adult transmission within households or close contact settings. So this was a Swiss study by Pasfay Barbe et al. That was published in Pediatrics that had interviewed 39 households and only found 3 or 8% of the households reporting child as the first person to develop symptoms. And their study was conducted during countrywide school closures and stay-at-home orders, which could have limited transmission among children. And in addition, they had a relatively small household size with, I think their median was 2 household contacts per home. So for our study, we evaluated pediatric patients less than 18 years of age that was seen at Children's Healthcare of Atlanta at any campus, including our urgent care and EDs, between March 16th and June 14th, 2020. We utilized a prospective registry of laboratory confirmed pediatric SARS-CoV-2 cases, and then randomly selected families and conducted phone interviews of caregivers to characterize the presumed transmission before and after the child's diagnosis. And we obtained demographic and clinical data through manual chart abstraction in Epic, and then placed all of our data into REDCap. So parents or legally authorized representatives were contacted at least 14 days from the date of the patient's positive test. And this was to allow for 1 full incubation period to pass. We obtained verbal consent and then conducted interviews in English or Spanish, depending on the family's preferred language. The survey addressed patient symptoms duration, household contacts with symptoms, both child and adults, and then also if household contacts had a laboratory confirmed diagnosis. In addition, we also asked about occupational risk factors, school exposure, smoke exposure, and vaccine hesitancy. We then defined positive household contacts by either a positive SARS-CoV-2 laboratory test, or we also considered them positive if they had at least 2 clinical symptoms of COVID-19 infection. So this was fever, shortness of breath, myalgias, cough, loss of taste or smell. So we initially had collected 32 parental surveys that began pretty shortly after school closures. The median age of our initial cohort was 12.7 years, and there was a slight predominance of males at 53%. Our population was pretty diverse, with 47% of Hispanic ethnicity and 25% of Black race. 37% of our patients had no comorbidities, 34% had asthma, and 44% were obese. Most patients were symptomatic at home for at least 5 days prior to seeking care, and 47% of patients were admitted to the hospital for a median length of stay of 3 days. Interquartile range was 2 to 13, and then 53% were seen in the ED or urgent care and discharged home. So we identified a total of 144 household contacts, 58 children, and 86 adults. Our median household size was 4.5 individuals in our cohort, and a total of 67 household contacts developed symptoms, 36 before the patient's first symptom, which was 14 children and 22 adults, and 31 developed symptoms after the patient, so 11 children and 20 adults. And household contacts developed symptoms and a median of 4 days before and 4 days after the patient. Out of the 32 households, we also found that 7 households, or 22%, had a child that was the first ill person in the home, and we suspected these patients to be the index case of their household. 3 were in school or daycare within 14 days prior to their symptom onset. 1 had exposure to a positive relative that was living outside the home. And then 3 had unknown exposures. And of these 7 patients, approximately 46% of the household contacts eventually developed symptoms or tested positive for SARS-CoV-2. So our initial study was published in June 2020. However, as the pandemic has evolved, we have seen this shift from higher infection burden in older populations to now more younger populations. And specifically looking at pediatric data, so pediatric patients less than 18, you can see that the percent positive between April and September has significantly increased, and is now comparable to adult percent positivity and maybe even surpassing adult rates. Specifically, we can see that as we've moved through this pandemic, children are as likely to become infected as adults. And although in this MMWR report, children aged 5 to 11 may be less likely than adolescents to test positive, it could also be that they're not getting tested because they're more likely to be asymptomatic. In addition, there's been a few outbreaks in pediatrics. So in June 2020, there was an outbreak at a summer camp in Georgia where you can see patients 6 to 10 years of age had a 51% attack rate compared to 44% in adolescent patients 11 to 17. And this higher rate of infection from previous studies may be due to patients being tested regardless of being asymptomatic. And then there was also another investigation of 3 outbreaks in child care facilities in Utah that found a total of 12 infected kids associated with the facilities, who then infected 12 household contacts. However, these outbreak investigations still really didn't address child transmissibility compared to adult transmissibility. So this actually was just published this week in the MMWR weekly report, which was a case ascertainment study conducted in Nashville, Tennessee and Marshfield, Wisconsin. This occurred between April and September of 2020, and they identified index patients as the first household member with COVID-19 symptoms that also received a positive nasopharyngeal SARS-CoV-2 test. They identified household contacts that tested negative at diagnosis of the index case, and then followed them daily for 7 days and did some repeat testing. And of 191 household members identified, 109 or 53% of them tested positive in follow-up. And they found that 14 of these households had pediatric patients as their index case. And of these, they showed equal secondary attack rate of 53% in children less than 12 years of age, which was higher than the adolescents at 38%. This possibly shows that children may be as likely to transmit SARS-CoV-2 as compared to adults. And I would just like to point out that their demographics were a little bit different than ours. 75% of them were non-Hispanic white patients. And they also had much smaller household sizes with the median number of household members of 1. So our ongoing study has collected now a total of 84 interviews to date, and most recently has focused more on outpatient and ED urgent care visits, as this was some of our feedback from our initial publication. Our median age of these patients is 9 years, and our demographics show a slight shift from our original cohort, with slightly less in the Hispanic ethnicity at 28% and 37% of Black race. However, this may be skewed because we have a limited number of Spanish-speaking investigators conducting surveys compared to our English investigators. Approximately 18% have also reported using tobacco products in their home, which is slightly higher than our initial cohort, which actually reported 0 households initially. So just kind of some preliminary analysis of this data. We've identified 331 household contacts. 149 or 45% have also developed symptoms of COVID-19. Which was slightly less than the recent MMWR report that reported the 53%. 70 patients developed symptoms before and 79 after our patient who sought care. And there was 58 adults and 12 children that developed symptoms before, and 48 and 31 children that developed symptoms after. In addition, we currently have identified 21 or 25% of the households in which we suspected a child to be the index case. So during this period, school reopenings have been limited and quite variable here in Georgia. And a total of 6 of 21 of the households had a child attend school or daycare within 14 days of illness onset. Our median age of this smaller cohort was 8 years, with the interquartile range of 1.5 to 13.5 years. 43% were of Hispanic ethnicity and 33% of Black race. And they were contacted a median of 38 days after their positive test for the parental survey. There is a predominance of males of 62%, 24% were categorized as obese. And out of the 21 suspected child to adult transmission cases, 37 adults developed symptoms after the patient, and 16 children developed symptoms after the patient. And interestingly, of these 16 children that developed symptoms after the patient, 10 of those were located just within 2 larger households. And then lastly, 7 children had developed symptoms before our patient among 4 households. And we suspected that the sibling was actually the index case in these houses. So our limitations to our study were that we did not rely on PCR testing for diagnosis of infection of household contacts, but used a combination of symptoms and/or testing. Adults that developed symptoms after our patient may have had a similar exposure to the patient, or but had a longer incubation period, or had a separate exposure completely. Our demographics were diverse and may not necessarily represent the rest of the US population, but has been consistent with some of the demographic inequalities that we've seen during this COVID-19 pandemic. And although this was a prospective study, we relied on survey data, which exposes our study to recall bias of the parents. So what has now become increasingly important is vaccines in children. So currently there are no clinical vaccine trials that have included children. And as children are showing an increasing role in the transmission of SARS-CoV-2, this really should be prioritized. In addition, in our parental survey, approximately 44% of families state that should a SARS-CoV-2 vaccine become available, they would not allow it to be given to their child. And they listed reasons such as safety concerns, the effectiveness of the vaccine, and how rapid the vaccine trials were progressing as reasons why they would not get the vaccine. So education of vaccine safety and efficacy should really start now, in addition to including children in our vaccine clinical trials. So, there's a lot more analyses that can be done with our data, but some of our future directions that we've discussed are now we're doing a multi-site study with planning to make comparisons of demographics and their study results with Mimi Kao, who is now in St. Louis. We are also going to compare pre and post stay-at-home order survey data and kind of see differences in transmission before stay-at-home orders or during stay-at-home orders and now after stay-at-home orders have been lifted. And then looking more in depth into vaccine hesitancy questions and concerns posed by families so that we can start addressing those concerns. So our conclusions are that children appear to be less likely to be infected with SARS-CoV-2 as adults. Children do play some role in transmission, although studies suggest it might be to a lesser degree than adults. More robust studies are needed to further define children's transmissibility. Social distancing and mask wearing is important in children to help limit spread in the community. Vaccine trials should include children if the US wants to limit educational, physical, psychological, and financial burdens on society. And addressing vaccine hesitancy among the community should really start now. So thank you everyone for your time and also allowing me again to present at the COVID-4 seminar series, and I'm happy to take any questions.
That was terrific. Thank you so much. We do have a couple of questions. So one is, why did you follow families for only 7 days when the incubation period is 14 days?
So that was a previous MMWR study. That wasn't our study. So what we did was we had the patient when they were diagnosed. We called the families at least 14 days after their positive test so that we could allow for the full 14-day incubation period before evaluating other household contacts.
Great. Okay. And what was the underlying assumption for looking at tobacco use in the household? And was this smoking, vaping associated with so even associated with tobacco use?
So we initially asked the tobacco questions because we didn't know at the time, this was at the beginning of the pandemic, what was a risk factor for having more severe disease. And initially we were only testing patients who had severe disease. So our cohort was a little bit more ill than it is now. So we were asking those questions to kind of look to see if tobacco use was a risk factor for having COVID-19 or having more severe illness.
Okay. And so what ultimately is your recommendation for testing of children when they seem to have symptoms, and how can families best manage their households when they have a sick child and they're trying to avoid transmission to other members of the household who may actually have comorbidities, et cetera?
Yeah, so that is a great question. So, obviously, I think a big issue is, people can transmit the virus while being asymptomatic. So really catching the diagnosis early and isolating the positive patients as best you can from the remainder of the family members during their infectious course, which we say is 10 days after the positive test. And then mask wearing if, social distancing isn't available. But yeah, really just isolating the patients early and limiting the amount of time that they're exposed to other family members.
So are you, though, actually encouraging them to get tested? Because, that's not necessarily what we always do in the emergency department, because we don't have any treatment, so it doesn't change anything. But I think that also assuming it's positive and isolating for 14 days can be a burden to families too. So what are you guys telling families, that they should do? Should they get tested, or should they just supportive care?
I mean, I don't think it really matters. I think you could get tested or you couldn't get tested, but regardless, if a patient is having symptoms, they should be, social distancing and isolating from family members that aren't symptomatic. And we usually say, 10 days from either when they got the positive test or maybe when they show symptoms, waiting 10 days before going back to meet the other family members.
We have a couple of more questions coming in. Is the incidence of asthma and obesity higher in the kids who seem to be getting COVID-19, or at least those that are being tested for COVID-19?
Yeah, so I think both asthma and obesity have been shown to be a risk factor for having more severe COVID-19 infection compared to those who are maybe asymptomatic or show very few symptoms.
Okay, and then lots of comments about great talk. Let's see, are there epidemiologic differences between the kids who appear to be the index case versus when compared to those who were not, so the subsequent cases?
Sorry, can you say that one more time?
Are there epidemiologic differences between the kids who appear to be the index case versus when compared to those who are not the index case?
From what we can see so far, we haven't found anything significant that, would allow the child to be the index case versus not. I think it depends a lot on their exposures So, you know, if they're in school or not, if they're hanging out with their friends, if they're participating in activities outside of school, like football practice, or now I know they're starting band practice. So, you know, I think it depends on their exposures. If they're out and about in the community, they're more likely to get COVID and bring it back to the home.
Sure. Okay. Let's see. Well, that really is fantastic. We're gonna move on to our next talk now. Pratik, if you could actually share your screen, and thank you very much for that informative presentation. Keep up the good work.
Yeah, thanks, Megan. It's saying I can't share screen while other participant is sharing. Okay, now I can do it.
Okay. All right, and while you're sharing your screen, I will get started and introduce Dr. Pratik Patel. So he is a third-year pediatric hematology oncology fellow at the Affleck Cancer and Blood Disorder Center at Emory University and Children's Healthcare of Atlanta. He completed his undergraduate and medical education at the University of Virginia, and he did his pediatric residency training at University of Texas at Southwest in Dallas, Texas. His clinical and research interests include the epidemiology of opportunistic infections, antibiotic stewardship, and immunocompromised patients, and clinical trials and the implementation of new diagnostic tests and antimicrobials. Through his involvement with Affleck, the COVID-19 task force, he's been fortunate to contribute to his division's response to the COVID-19 pandemic and work on various research projects. He was involved in the recent publication of severe COVID-19 disease in 2 pediatric oncology patients that was published in Pediatric Blood and Cancer. His mentor is Claire Stokes from the Pediatric Hematology Oncologist at Affleck Cancer and Blood Disorder Center. And his talk today is entitled The Clinical Features and Antibody Response of 2 Pediatric Patients Presenting with New Onset Acute Myeloid Leukemia and Concomitant Severe COVID-19. Thank you so much. Take it away.
Great. Can you guys see my screen?
We can.
Okay. So thank you for that great introduction and allowing me to present some of our work today. I'm really excited to present this because it's kind of been a cool experience to collaborate with our ID colleagues and within our Affleck Cancer and Blood Disorder Center to kind of look at some of this, the COVID epidemic in our patient population, especially these 2 cases that posed an interesting therapeutic and kind of clinical questions. So really my collaborative team is some of the mentors from Affleck as part of the Affleck COVID-19 task force, and then the folks over at the Center for Childhood Infections and Vaccine with Dr. Rostad and her research assistant, Stacy Lapp, and then Evan Anderson as well. So just a brief introduction on the intersection of oncology and COVID-19. So as a primer, adult patients with COVID-19 and cancer tend to do poorly. And I think cancer is listed as one of the special populations on the NIH treatment guidelines, especially because some of those patients do worse overall in terms of hospitalizations, morbidity, and even mortality. Specifically, adult patients with hematologic malignancies, such as leukemias, have been a subset of population that tend to do worse within just adult oncology patients. When you look at the published literature on the clinical course of COVID-19 and pediatric cancer, it's generally been described as a mild course. And there's 2 publications kind of early on in the pandemic, one from GM Oncology at Memorial Sloan Kettering in New York City, and one from Northwestern in Chicago. And between the 2 of them, of 26 patients that had pediatric oncology diagnoses and COVID-19, all of them were described as relatively mild without any kind of intensive care use, as well as mechanical ventilation or even mortality. And so the next step in determining kind of what to do with COVID-19 and cancer therapy, especially in the face of a positive infection, I think is largely unknown. And so one of the things to consider is if a patient is positive for SARS-CoV-2, with this data being so conflicting, like adult patients doing worse and then pediatric cancer patients doing okay, what to do with cancer therapy in the face of a positive infection is unknown, and really unknown from the level of adults as well as pediatrics. And so I wanted to introduce acute myeloid leukemia just for the folks in the room that are oncologists. So leukemia in general is the most common cancer in pediatrics. And most of these leukemia patients are acute lymphoblastic leukemias, but a small portion are acute myeloid leukemias. The outcomes for AML have an overall survival of 60 to 70%, which depending on your outlook is good or bad. But for context, the overall survival in pediatric ALL is around 90%, so still lags pretty significantly. Chemotherapy for acute myeloid leukemia is definitely one of the most myelosuppressive regimens that we use in all of pediatric oncology, short of a stem cell transplant. And due to this, treatment-related mortality, with the main cause being infection as the etiology for mortality, is a major problem within AML treatment in our patient population, and especially within the adolescent and young adult population. So as you can see from the graphs, which were published by Cantor et al. In 2013, on the left is looking at, and so this is a compilation of 4 trials within the Children's Oncology Group, looking at AML outcomes and then stratified by age. So age being less than 16 as kind of the younger population, and then age 16 to 20 being the adolescent and young adult population. And on the left, you can see overall survival does not differ significantly between the two populations. But on the right, you can see treatment-related mortality does differ significantly. So the adolescent and young adult population has a treatment-related mortality of around 25% in adolescents and young adults, and about half of that, about 12.5% in the younger population. So why is this? One of the possible explanations has been that the pharmacologic differences in chemotherapy may differ between these two populations, and hypothesizing that AYA patients may have a relatively decreased clearance of chemotherapy agents, and thus prolonged drug exposure could lead to increased severity of toxicities such as myelosuppression and mucositis, and thus introducing opportunities for infections. Others also hypothesize that AYA patients' adherences to supportive care measures such as oral, skin, and central venous line care, and taking prophylactic antibiotics, antimicrobials may be less than younger patients who may have adults and be a little bit more on top of them about doing those measures. So thus we looked at this, we wanted to look at these 2 patients who both presented with a new diagnosis of acute myeloid leukemia and concurrent COVID-19. And so we looked at the clinical presentation, the treatments, both from a COVID standpoint as well as an AML standpoint. And then interestingly enough, through our collaboration with Dr. Rostad and her group, we're able to look at the SARS-CoV-2 serology of the 2 adolescents over time. The study was approved by CHOA and Emory IRBs respectively, and the clinical presentation and treatment outcomes were done through retrospective chart review, and the residual, and then the serology was done through residual blood testing for quantitative IgM and IgG by ELISA to the SARS-CoV-2 spike protein receptor binding domain. And the S protein receptor binding domain is the part of the virus that binds to the ACE2 receptor on cells, and then this enables the virus to infect and enter the cells. And work here at Emory has actually shown that this antibody is a very high sensitivity and specificity to SARS-CoV-2 versus like other coronaviruses. And then this antibody response actually correlates well with neutralization assays, which I'll describe a little bit later as well. So the presentation of patient 1. So this was a 16-year-old male who presented with a history of classical Hodgkin's lymphoma. So actually he had under a previous diagnosis of cancer about 2 years ago, and was off of chemotherapy for about 2 years when he presented with new onset fever, cough, hyperleukocytosis, and pulmonary airspace disease. He had nasopharyngeal swab testing for SARS-CoV-2 via RT-PCR upon admission. And this was actually done early in the epidemic. So he actually was tested because his father was an employee at our funeral home, which was the source of a local outbreak. And so he was ultimately diagnosed with therapy-related acute myeloid leukemia, likely due to secondary leukemia development due to exposure from previous chemotherapy agents. And so when it came time to determine his induction chemotherapy, given that this was relatively early in the outbreak and we didn't really know kind of any literature on kind of outcomes at this point, there was concerns for cardiotoxicity with the standard kind of triple agent ADE chemotherapy regimen that we use in AML treatment. And given that there were some early reports of cardiac adverse events from COVID, as well as consideration that this patient with an underlying diagnosis of therapy-related acute myeloid leukemia really needs a bone marrow transplant for curative therapy, due to prior work showing that. And so given that he would need kind of bone marrow transplant as his curative therapy, we prescribed him kind of single agent cytarabine mono agent chemotherapy for his AML, which started on hospital day 3. And as you can see, he did relatively well from a COVID standpoint. He actually only required some supplemental oxygen with high flow nasal cannula as his maximum support. He was in the ICU due to his oxygen requirement being so high versus what's allowed on the floor. And he was treated with hydroxychloroquine and remdesivir for his COVID-19. And as you can tell, this was pretty early on in the epidemic when we still thought that hydroxychloroquine was useful. And here is the serology kind of laboratory results from this patient. So I'm going to kind of walk you through it. So on the left-hand side, you can see is a column that is the days from COVID-19 symptom onset. So this is important just because some of the patients may have had symptoms before they presented to the hospital. And so we wanted to include that as a variable. And then you can see hospital day with 0 being the day of admission. We also included absolute lymphocyte count. So we thought this was interesting because the lymphocytes are how you develop your antibodies. And so we wanted to look at that as well because lymphocyte count will decrease with chemotherapy administration. And then we looked at IgM and IgG antibody titers to that spike protein receptor binding domain. And then we also have the RT-PCR results listed here. And we had repeated results here. And again, this was kind of early on in the epidemic when we were still testing patients frequently to see if they had cleared the virus for isolation purposes. And so the interesting thing to note here is that upon first testing at hospital day 4, and about 7 days after presumed onset of COVID-19 symptoms, the patient had both IgM and IgG antibodies to SARS-CoV-2. Even in the face of kind of active, unchecked AML leukemia. Given the patient's initial chemotherapy regimen of low-dose cytarabine, single-agent cytarabine, the patient did not really become lymphopenic as evidenced by a persistent ALC of greater than 500 and continued to mount a good immune response as evidenced by increasing titers to IgG during the first 30 days of hospitalization. The early mounting of this immune response likely contributed to some element of clearance of his SARS-CoV-2 with his nasopharyngeal RT-PCR testing turning negative on hospital day 16. So this is kind of showing that, the ALC didn't really drop below 500 and because of this, or maybe due to this, his IgG titers kind of increased over time. And his RT-PCR testing went from positive to negative from hospital day 0 to 16. And this is just the graphical for those of you who like graphs that shows that due to a persistent lymphocyte count, we also see an increasing in his IgG titer. So his ultimate, his patient clinical outcome. So from a leukemia standpoint, he had bone marrow testing on hospital day 20. Which for those of you who don't know, for leukemia testing, we can look at both morphologic, so pathologic under the microscope, to look at blasts and see if there's evidence of leukemia that way. But then we also have kind of newer testing which looks at flow cytometry, which uses flow cytometry testing to look at kind of a more in-depth, high throughput testing to see if there's any residual leukemia cells. So on his morphology, he had some rare blasts, less than 5% by the hepatopathologist, but on his minimal residual disease testing was negative for AML cells. So this patient, because he had only received single agent cytarabine therapy, received subsequent chemotherapy for his induction, which included azacitidine and gemtuzumab ozogamicin, starting on hospital day 26. And then ultimately, the first cohort, I had presented this at a meeting where we kind of cut it off at hospital day 30. But now, I just wanted to include the rest of his hospital course as well. So post hospital day 30, he actually developed pretty significant Pseudomonas bacteremia, which was thought to be secondary due to a perirectal abscess, which also grew Pseudomonas aeruginosa, and then he also developed EBV viremia and ultimately died and passed away on hospital day 74 due to multi-organ failure. So it's not actually attributable to COVID because he had, likely cleared his COVID infection as evidenced by negative RT-PCR testing. So now I want to talk a little bit about patient 2. So patient 2 presented a month or two later and he was a 19-year-old male who presented with no significant past medical history and came to us with a symptomology of fever, cough, dyspnea, and hyperleukocytosis. His COVID-19 risk factors included working in a factory and warehouse throughout the epidemic, and so having exposures to lots of workers. And then he was ultimately diagnosed with de novo acute myeloid leukemia. And so de novo being that his was not attributable to prior therapy. And given that at that time, we actually had consulted some of the adult colleagues, and a lot of literature was saying, to go ahead and just treat patients with kind of standard chemotherapy, given that the COVID outcomes in pediatrics were a little bit mild compared to adults. And given that he was 19, he's kind of considered borderline in terms of, in oncology, we would treat these patients as on pediatric regimens, but technically he is an adult patient. And so he was prescribed, and given that he had de novo AML therapy, and where getting into remission and induction is very important for AML outcomes, he was prescribed standard triple agent chemotherapy of cytarabine, daunorubicin, and etoposide, which started on hospital day 2. His COVID-19 course was unfortunately complicated, as even on hospital day 4, he developed significant respiratory failure, requiring intubation and mechanical ventilation. And then for his COVID-19, he actually received various therapies, including convalescent plasma, remdesivir, and due to remarkable symptoms of hyperinflammation, tocilizumab on hospital day 11, and even received therapeutic plasma exchange with subsequent convalescent plasma administration on hospital day 12 and 13, as you can see on the graph on the right. So he actually had a very complicated COVID-19 course. And when I presented this at the prior meeting, within that first 30 days of hospitalization, he actually remained on mechanical ventilation throughout that period. And so his antibody course is actually very interesting. So as you can see, the patient had a pretty persistent, a pretty significant lymphocyte count at presentation, although a large portion of these were likely AML cells. And then very quickly on hospital day 12, his ALC dropped to 0, given that he was prescribed the traditional kind of myelosuppressive AML chemotherapy. And then you can see his antibody titers were actually very minimal initially up until hospital day 17, which seems to have kind of gone along with his ALC count. And then interestingly enough, his RT-PCR testing continued to be positive throughout his first 30 days of hospitalization. And even starting on hospital day 25, where he starts to develop an ALC, starts to develop some antibodies, and then, even on hospital day 31, which is even more potent response, he still continues to test positive for SARS-CoV-2 via RT-PCR. And this was in the face of receiving convalescent plasma as well, and the various other therapies for COVID-19. And so here's his graph, so showing in blue how his ALC drops quickly to about 0, given that he was given pretty myelosuppressive chemotherapy, and then his IgG taking a while to kind of develop once he developed ALC again afterwards. As far as his clinical outcomes, so he, on bone marrow testing on hospital day 25, had no morphologic evidence, and his MRD testing was negative, so he was in remission. And post-hospital day 30, he actually continued to have prolonged respiratory failure. He had renal failure as well. And actually on hospital day 48, he suffered a sudden cardiac arrest, likely secondary due to septic shock. And at that point, he had actually cleared his SARS-CoV-2 virus, but he was still having some significant complications from that and almost was considering a tracheostomy at that point. So this is interesting, but you know, some of you may be asking, but how do we know that patient 2's persistently positive RT-PCR results weren't just residual virus and not actually clinically relevant? And so one way that you can potentially look at this is looking at the PCR amplification cycle threshold values, the CT values. So RT-PCR testing, the cycle threshold values are a way for you. And so cycle threshold values are the number of cycles it takes for the ELISA to detect, or for the RT-PCR to detect the fluorescent signal. So meaning if it takes less cycles to detect the signal, it indicates higher amounts of viral nucleic acid, which is what that RT-PCR is testing. And so that's one way to maybe gauge levels of viral nucleic acid. And again, it's not live virus, it's not testing viral load, but it's maybe a surrogate for that. And then again, so you can have antibodies, but do those antibodies functionally work to prevent virus? And so one way that we can do this is doing a focused reduction neutralization test, in which we incubate the serially diluted serum of the patient with live virus, followed by infection and incubation of cells, and to see, and then ultimately to see what percentage of cells have uptake of the virus. And so we could do this with collaboration with Mehgan, also at Emory University and on the pediatric and adult side. So this is some update to those results, which are actually very fascinating. So patient 1, we actually didn't have any CT values for him because his testing was send out testing, and we actually, at so early on in the pandemic, we don't have access to those CT values. But interestingly enough, his neutralization test results show that he had kind of a mild neutralization geometric mean titer. So this is again a titer early on, and maybe that contributed to his being able to neutralize and kind of clear the virus, and then it kind of waned over time. And then patient 2 had a very interesting kind of profile. So his CT values were actually very kind of moderate high up until kind of hospital day 25, even 31, with ranges of CT values of in the teens and even in the 20s. And this is both for the S protein and the open reading frame 1 antibody. There are 2 different CTs and primers that are used for the RT-PCR with our CHOA laboratory. And then this actually seems to have correlated with his neutralization assay results, which showed, you know, no neutralization early on, which is not surprising because he didn't have antibodies. But then ultimately, when he developed these antibodies, robust antibodies, he actually had very strong neutralization test results, which showed kind of correlated with like a decreasing titer or decreasing CT values. And ultimately, on hospital day 48, he tested negative for SARS-CoV-2. So conclusion, severe COVID-19 in the face of new diagnosis of AML poses a therapeutic challenge, because while we do want to continue to have good outcomes from an AML standpoint, we do want to respect the kind of severity of the COVID-19 as well. Newly diagnosed AML patients undergoing induction chemotherapy can mount an IgM and IgG immune response, as evidenced by patient 1. But patient 2 seems to have his viral clearance seems to have correlated with the intensity of chemotherapy received by the 2 patients. And, you know, while hard to make definite conclusions from 2 patients, it seems that the viral clearance correlated with the intensity of chemotherapy, which actually, you know, may have correlated with the development of their serologic responses as well and neutralization responses. So the next steps, so because of this kind of interesting results and, a large population of our patients having COVID-19 and testing positive for COVID-19, together with Dr. Pauly from AFLAC and Dr. Rosset and Dr. Anderson, my plan is to apply for some funding from the Woodruff Health Science Center, COVID-19 Center for Urgent Research Engagement Cure Awards Program to expand on these findings by studying the serologic outcomes in pediatric leukemia and lymphoma patients. We have actually had about 25 patients, pediatric leukemia lymphoma patients test positive for COVID. And so I think we do have a nice population to be able to study immunosuppress patients and their serologic outcomes. And so we're also planning to complete and submit a manuscript for these patients in a peer-reviewed publication. Interestingly enough, we have actually had 3 other patients who've been newly diagnosed with ALL, the other main leukemia subtype that I talked about earlier in pediatrics, and COVID at the same time. And so, with the help of Dr. Rostad and her lab's findings, it'll be kind of interesting to see what those patients' outcomes will be from a serologic standpoint as well. Dr. Rostad has the blood samples from them, but we haven't been able to run them yet. So I wanted to open it up for a little bit of questions. I know that was kind of a lot of data and may have created some interesting questions. And unfortunately, with 2 patients, it's hard to kind of speculate and conclude too much, but we may be able to do that a little bit further if we're able to get some award funding to study it in a broader population.
Well, fantastic. Thank you. That is such important work. I just want to remind everyone to put their questions in the chat box, and I will start out with, so are you thinking, especially now that you've got, 2 more cases, that this is too true and unrelated? Or have there been other reports of new AML because I'm thinking like EBV, right? So we see, oncologic complications associated with other viruses, and is that a possibility?
Yeah, so, I think some literature has hypothesized, there is some literature about the kind of infection hypothesis of how ALL or leukemia develops. And so some people are thinking that, in SARS-CoV-2, could that lead to development of leukemia? They've actually found the opposite sometimes. Some centers, including CHOP, has reported that their new diagnoses have actually dropped during the pandemic. Part of that has been maybe delay and kind of access to care, but in general, they've just noted kind of lower numbers. And that could be also because of the opposite effect where people are actually isolating and not getting as many other infections. And so maybe that's actually leading to less kind of development from an infection standpoint. From a leukemia standpoint, I think, I actually think other centers have actually, I'm actually presenting some research at the American Society for Hematology conference in December. And they actually had an abstract that was just a couple of days ago, where in Brazil, they had 8 patients who were pediatric patients who were newly diagnosed with AML and COVID at the same time. And they actually had very kind of good outcomes, but they reduced treatment for all of those patients to a lower intensity treatment, given that they had resource limitations in Brazil to be able to care for those patients. And so they gave them kind of milder chemo overall, and they seem to have done okay from an AML standpoint in terms of remission as well as COVID-19.
Maybe we'll learn something from Brazil.
Yeah.
Okay, we do have a question. SARS-CoV-2 has both a lysogenic and lytic phase. Do the serologic responses correlate with the viral life cycle? And how do these phases impact the CRS?
So I actually don't know if the serologic responses of the IgG and IgM correlate with viral life cycle. That might be a question that maybe like some of the ID folks on the call can answer. I haven't read that much into the literature about the viral dynamics.
Any of the infectious disease folks want to take a stab at that? Andy, I see that you're on now, or Andres.
I don't know the answer to the question, and I don't know. I think for Pratik's specific situation, I think would be difficult to know exactly at what time the viral cycle was, what type of viral cycle the patient was. So I would not know how to answer that question.
Yeah, I don't, know the answer either, but I'm sure we could potentially ask. Does the person who asked the question know or have thoughts about it?
Curtis, did you have any thoughts?
Maybe not.
Hey everyone, I'm here. Sorry.
Curtis, thank you.
Yeah. I have a 1-month-old son here, and so I'm actually trying to play double duty here. I think obviously in the context of looking at this in patients, it would be very difficult. But if you could model this in vitro, where you could essentially do PCR for different components of the viral particles that are only produced in the oncolytic versus the lysogenic phase, and then try to correlate that with the serological response in terms of antibody binding. That's at least one in vitro assay that may help you get to that. But obviously, as you mentioned, in patients, it would be very difficult to do, but may be achievable in vitro. And I don't want to take up a lot of time here because this is Teek's, great work, and I want to hear what he has to say. But I'm certainly willing to speak offline about ways to model this in the lab.
Yeah, that's interesting because we do have two different kind of CT values, and then at least for right now, we have the antibody response from the receptor binding domain of the S protein, and we've actually collaborated with a researcher at the FDA who's looking at antibody kind of profile in general and different isotypes as well.
And just a quick question about the question. Are you talking about the cycle in the cell and replication? Because then in a person, you're going to have the whole range of cycling in cells depending on the time a given cell got infected.
Yes. So yes, exactly. So which is why I think maybe looking at this in vitro might be somewhat informative. Because like you mentioned, at any given time in a patient, you're going to have cells where the virus is basically hiding out in the lysogenic phase versus, periods where, the cells are being lysed because the virus is making progeny. So I was just wondering, if you have cells that, if in a patient, or I guess in addition, in this case, if the cells are more in the lysogenic phase, are the antibodies actually being generated and are they actually hitting their targets effectively versus if you have a more, in theory, potent immune response because you're you're activating RIG-I, MDA5, all of these antiviral immune responses, are you getting a more robust viral antibody titer, and are they working better? So that was essentially the foundation of that question. I'm just curious has anyone looked at viral life cycle versus the type of antibody response you actually get out, which again would be more feasible to model in vitro and obviously difficult to dissect in patients.
So I'm going to ask this last question is interesting before we close up here. So does AML impact the viral tropism or the expression of the ACE receptor?
So I actually don't think it impacts the expression of the ACE receptor in patients, just because the ACE receptor is found on kind of physiologic human tissue as well, and so it wouldn't necessarily affect expression at that level. Viral tropism, that's a whole different thing, and I think probably hasn't been looked at just because currently the literature in terms of oncology and COVID has kind of just been at, what are the risk factors, what are the kind of chemotherapy agents that are kind of risk factors, and then they're starting to get a little bit more data now coming out about serologic responses, but even that has been mostly in healthy patients and not really in immunocompromised or immunosuppressed patients. So I think that's what makes our work a little unique, is that we're already having some of that data.
Excellent. Well, thank you so much. We're coming up on 1 o'clock. So I want to thank our speakers for really engaging talks. And this is going to end our COVID Force Collaborative Seminar Series. I just want to mention that this has been co-sponsored by the Center for Childhood Infections and Vaccines, the CCIV, and the Center for Clinical and Translational Research, the CCTR. Thank you so much for your participation.
before you leave, we just want to put a plug in for the November 20th seminar, which we do have coming up in a couple of weeks.
Perfect.
Thanks, guys.
Great job.